Hello everyone, and welcome to another episode of Medical Insights on our Dobbs Channel. My name is Daniel, and today we're diving into an important topic, particularly for healthcare professionals working in obstetrics and gynecology: iron deficiency anemia, or IDA, in Asian women. This episode is based on expert consensus and practical recommendations aimed at improving the diagnosis and management of IDA in women during pregnancy, postpartum, and in cases of heavy menstrual bleeding. Iron deficiency anemia is one of the leading causes of anemia worldwide. Asian women are especially vulnerable due to dietary patterns, the high prevalence of heavy menstrual bleeding, and frequent pregnancies, all of which increase the risk of developing IDA. Let's begin by discussing screening and diagnosis. According to expert recommendations, all pregnant women should undergo screening for IDA during their first prenatal visit. If hemoglobin HB levels are found to be less than 11 grams per deciliter, further evaluation and treatment are warranted. It's also recommended to repeat screening at the beginning of the third trimester because iron demands increase significantly as pregnancy progresses, raising the risk of late-onset anemia. Postpartum screening is equally critical, as iron stores often remain depleted after childbirth, leaving women susceptible to postpartum anemia. Next, let's move on to treatment strategies. The choice of treatment depends on the severity of anemia. For mild anemia, defined as HB levels between 9 and 10.5 grams per deciliter, oral iron supplementation is recommended as the first-line therapy. However, in cases of moderate to severe anemia, or when patients are intolerant to oral iron, intravenous, IV, iron therapy is preferred. IV iron provides a faster and more reliable means of restoring hemoglobin and iron stores, especially in high-risk conditions, such as late-stage pregnancy or in patients with a history of heavy menstrual bleeding. In severe cases, where HB levels drop below 7 grams per deciliter and symptoms are significant, blood transfusion may be necessary. The guideline emphasizes administering a single unit of blood at a time, followed by reassessment to minimize risks associated with overtransfusion. Once treatment is initiated, monitoring and follow-up are essential. Hemoglobin levels should be checked after 2 to 3 weeks. A good response to treatment would be an increase of at least 1 gram per deciliter. If the increase is less than that, it's important to investigate possible causes, such as poor adherence to treatment or ongoing blood loss. After hemoglobin normalizes, it's advised to continue treatment for another 3 months or until at least 6 weeks postpartum to ensure adequate replenishment of iron stores. Let's address some practical challenges commonly faced in managing IDA. One frequent issue is poor compliance with oral iron therapy due to gastrointestinal side effects, like constipation or nausea. In such situations, switching to IV iron may be more effective in ensuring patient adherence and achieving better outcomes. Another challenge involves distinguishing IDA from other causes of anemia, particularly in regions where thalassaemia is prevalent. In such cases, additional tests like serum ferritin and transferrin saturation can help confirm the diagnosis of IDA. In summary, effective management of iron deficiency anemia in Asian women requires a systematic approach: early screening, appropriate treatment based on severity, and diligent follow-up to ensure treatment success. By tailoring interventions to individual patient needs, whether through oral or intravenous iron, we can significantly improve outcomes for our patients. That's all for today's episode of Medical Insights on the Dobbs Channel. I hope you found this discussion helpful. If you did, please share it with your colleagues and stay tuned for more insightful episodes. The link to downloading the PDF guide is in the video description.